Have you ever looked at an older relative's medication list and just felt overwhelmed? Or maybe you've heard that old saying, just take it easy as you get older, especially with health stuff.
Right. It often feels like there's more to it, doesn't it? A whole hidden layer.
Exactly. And today, that's what we're digging into. We're peeling back those layers.
Yes, we are. We're taking a proper deep dive into the special aspects of geriatric pharmacology.
Yeah.
And it's way more than just tweaking dosages.
Mm-hmm.
It's really about understanding how our bodies fundamentally change over decades and how those changes totally rewrite the rules for how drugs work within us. It's a field that demands real expertise.
And that's our mission for you, the listener. We want to give you a kind of shortcut, not to simplistic answers, but to genuine mastery.
Yeah, the kind of understanding that top professionals in this field have.
Right. We want to equip you with that nuanced view to see exactly why drug therapy for older adults is so different, so challenging, but also so incredibly important.
And we've got a solid base for this. We're leaning heavily on KATZUNG's Basic and Clinical Pharmacology, the 16th edition. It's a really authoritative text, so this isn't just guesswork.
No, it's grounded. And the relevance, it's just exploding, isn't it? You look at the demographics.
Absolutely. Average lifespan in many countries is pushing 80, even past it.
It's a huge shift.
A dramatic expansion of the older population. And what that means for medicine, well, it's pretty clear. The need for really informed, really precise, personalized drug treatment for older adults. It's not just growing, it's becoming absolutely central.
The stakes are incredibly high. For individuals, for public health.
Couldn't be higher. So, okay, to really get our heads around geriatric pharmacology, we kind of have to start with a basic question. Who exactly are we talking about when we say elderly?
Right, because it feels a bit vague sometimes.
It is. Society often just lumps everyone over 65 into that elderly category. But, in geriatrics itself, the field often focuses more on people over 75.
Okay, a slightly higher bar.
But even then, experts admit it's still pretty arbitrary, just a line in the sand, really.
So it's not like a switch flips on your 65th or 75th birthday.
Not at all. That's the crucial point. Chronological age, just the number of years, is only an indirect clue about the physiological changes that actually matter for drug therapy. The variability between individuals is massive. You could have an 80-year-old who's incredibly fit, runs marathons, and handles meds like someone half their age.
Right next to someone who's maybe 65 but frail with multiple conditions.
Exactly. And their body processes drugs completely differently. So it's that individual variability, that biological reality, not just the calendar age, that has to guide how we approach things.
Makes sense. It's the person, not just the number. And with aging, it seems like there's a whole constellation of specific conditions that become much more common beyond just the usual adult stuff.
Oh, absolutely. Besides the chronic diseases we see across adulthood, older people face a much higher rate of really specific challenges. Think neurodegenerative conditions, Alzheimer's, Parkinson's, different kinds of dementia. Stroke risk goes way up.
All requiring complex meds, usually?
Often complex, often long-term management. Yeah. And then there are the senses.
Which we rely on so much for just, everything, including taking meds correctly.
Precisely. Vision problems are huge cataracts, sure, but also macular degeneration. That can make reading a tiny prescription label impossible.
Big barrier.
And hearing loss. Extremely common, especially in men. And that makes communication about drug regimens, understanding instructions really difficult. We'll definitely circle back to that.
I can see how a simple misunderstanding there could cause real problems. What about the heart and the circulatory system? Still major players, I assume.
Oh, definitely. Still leading concerns. Atherosclerosis, that hardening of the arteries, is widespread. Coronary artery disease, peripheral vascular disease, different types of heart failure.
All needing their own sets of medications, often multiple ones.
Typically, yes. Often lifelong treatments. Then you layer on the metabolic and musculoskeletal issues. Diabetes is more common, arthritis in its various forms, and of course osteoporosis and the risk of fractures, which can be devastating.
The list keeps growing, unfortunately.
It does. We also see higher rates of various cancers with age and things like urinary incontinence. It might not be talked about as much, but it really impacts daily life and often needs pharmacological help.
So the bottom line is?
The bottom line is this pileup of conditions creates a huge and constantly growing need for really thoughtful drug treatment in older people. And with populations aging globally, this need is just going to become even more central to healthcare.
It sounds like age isn't just one risk factor among many for these conditions, but often the strongest one.
That's a really key insight, yes. Even when you control for everything else, lifestyle, environment, other factors, age itself emerges as the single most powerful risk factor for the big killers and debilitators.
Wow.
Cardiovascular disease, neurodegenerative diseases like Alzheimer's, most cancers.
Wow.
It suggests there's something fundamental about the biological aging process itself that just makes us more vulnerable.
Which leads to the question, what is that fundamental process? What are we learning at the molecular level? Any secrets to longevity emerging?
Well, the research is fascinating, cutting-edge stuff. You look at nature, you find these amazing exceptions. Certain turtles and tortoises test tubes, they show almost no signs of aging, senescence over incredibly long lives.
They just keep going without breaking down like us.
Seems like it. It challenges our whole idea of aging as inevitable. It suggests maybe senescence isn't a universal law for all complex life.
Mind-boggling. Okay, what about things more relevant to us mammals?
Well, something known for a long time is caloric restriction, CR. Just cutting calories without malnutrition significantly extends lifespan in lots of animals, including mammals.
Right, I've heard of that.
And what's really interesting is it's not just about more years. It seems to be about better years. Studies suggest these animals stay healthier for longer and extended health span. They delay age-related diseases.
That's the crucial difference, isn't it? Quality, not just quantity. Are there drugs that can mimic this? Caloric restriction mimics, I think they're called.
Exactly. CRMs. That's a huge area of research, trying to trigger those same longevity pathways pharmacologically. And yes, there's progress. Drugs have increased lifespan in worms, in mice.
Any specific examples?
The big ones getting attention are metformin, the common diabetes drug, and rapamycin, an immunosuppressant. Each one alone seems to extend lifespan in animal models.
And together?
Even better, potentially. There seems to be a synergistic effect. The combined impact might be greater than just adding their individual effects.
A powerful combo, potentially. What about sirtuins? They always come up in longevity talks.
Ah, yes, sirtuins. They're a class of enzymes linked to lifespan regulation in some species. There was a lot of excitement about activators, like resveratrol from red wine.
Right, the red wine compound.
But despite the initial hype, resveratrol itself hasn't really panned out in terms of consistently extending life in mammals like mice. The pathway is still interesting for understanding aging, but those specific activators haven't delivered like people hoped.
Okay, so this research naturally leads to a huge question. If we found safe, effective drugs, maybe better than metformin or rapamycin, that really extend health span, should everyone over, say, 40 or 60 just start taking them?
That's the million-dollar question, isn't it? And it always comes back to health span versus just lifespan.
Yeah.
I mean, who wants extra years if they're years of sickness and decline? Very few people. The goal has to be delaying disease, keeping cognitive function sharp, staying physically vital. Any longevity drug would have to prove it delivers that to be widely adopted.
And it's not just about pills, right? Lifestyle factors are massive for health span.
Oh, absolutely. Regular exercise is probably the single best proven thing we can do for a longer and healthier life. Its benefits are just undeniable.
And some of the other research sounds almost like science fiction. Things like telomere length.
Yeah, telomeres, those protective caps on our chromosomes. There's evidence that their length might predict prospective lifespan. Generally, shorter telomeres correlate with shorter predicted life.
And what about the stuff about blood factors and rejuvenation? That sounds wild.
It is pretty wild. But there are studies, mostly in animals still, showing that plasma from young animals, or even from older animals that exercise a lot, can actually improve cognitive ability in older, sedentary animals when transferred.
Seriously? Like, it makes them younger somehow.
It suggests there might be rejuvenation factors or proteins in younger blood that could potentially reverse some aspects of aging at a cellular level.
Okay, wow. But I'm guessing there's a huge but coming.
A massive but. And this is critical for everyone listening. This is animal research. It offers zero current guidance for treating diseases in older humans right now. Fascinating science, potential future directions, but absolutely not ready for prime time or personal health decisions.
Understood. Purely research phase. Okay, so we've covered the big biological picture. Let's bring it down to earth with a real-world case. Tell us about the patient who embodies these challenges.
Okay, let's picture this. A 77-year-old man. His wife brings him in. He's had moderate hypertension, high blood pressure for about 18 years. But he admits he doesn't really like taking his meds.
Pretty common scenario.
Very. He says he feels fine, no complaints. But his wife jumps in, says he's gotten really forgetful lately, stopped reading the paper, stopped watching TV things he used to enjoy.
Okay, alarm bells ringing. What did the checkup show?
Well, they did a mini mental state exam, a standard cognitive screen. He knew his name, knew where he was, but couldn't tell you the month or year, couldn't remember his own kids' names, couldn't hold on to 3 random words for more than 2 minutes.
Wow, significant cognitive issues right there.
Definitely concerning. And then his senses. His wife mentioned he stopped reading.
Yeah, what was going on there?
No obvious cataracts, but he absolutely could not read newsprint without a really strong magnifying glass. Suggests macular degeneration, even without the formal eye exam yet. And his hearing seemed profoundly limited. He just sort of nod and smile at everything, whether it was a statement or a question, clearly wasn't understanding much.
That paints such a clear, complex picture. One person facing multiple interacting problems.
Exactly. And this case immediately throws up key questions. First, why isn't he taking his blood pressure meds? That screams adherence issues. Second, given the cognitive decline, what can actually be done for Alzheimer's disease? What are the real options? And third, how do you treat the suspected macular degeneration? This isn't just biology. It's behavior, it's social context, maybe economic factors too. It's the whole package.
A perfect illustration. Which leads us nicely into the next big topic. The general changes beyond just physiology that affect how older adults use drugs. It's the whole life context.
Absolutely. And one of the biggest drivers of complexity is simply having multiple diseases at once. As people age, they collect chronic conditions, comorbidities, and that almost inevitably leads to polypharmacy.
Taking lots of different pills.
Right, which immediately ramps up the risk of drug interactions, side effects, just the overall burden of treatment.
And it's not just diseases, but basic things like nutrition.
A vital point, often missed. Nutritional issues are common. Even mild dehydration can mess with kidney function, affecting how drugs are cleared. Severe malnutrition can impact liver metabolism. It all connects.
And then there's the cost. Meds aren't cheap, and many older adults are on fixed incomes.
A huge barrier. The high cost of drugs is a massive disincentive. It directly leads to non-adherence people skipping doses, splitting pills, just not filling prescriptions because they can't afford it. It's a major systemic problem.
And then the big one, adherence itself, or compliance. Our case study showed that. Why is it such a struggle for so many?
Oh, there are so many reasons. Simple forgetfulness, yes, especially with cognitive decline. Confusion about complex regimens. But physical issues are huge too.
Like what?
Like poor hearing makes it hard to understand the doctor's instructions. Arthritis makes opening those child-proof bottles, which are often elder-proof, as you said, really difficult.
True.
Poor vision makes reading labels impossible, trouble swallowing big pills. It's a whole range of practical barriers.
And sometimes it's not just an accident or a physical barrier, right? You mentioned intelligent non-compliance.
Yes, that's a conscious choice. Maybe they had a bad side effect last time. Or maybe their symptoms went away, so they think, logically, I don't need this anymore.
Makes sense from their view, but could be dangerous.
Exactly. It seems rational to them, but stopping a drug prematurely can have serious consequences.
So how should doctors or pharmacists handle this? It's clearly not just about telling people off.
No, absolutely not. You have to investigate why. Ask questions, listen empathetically, check if they truly understood the instructions, maybe have them repeat it back. Provide clear written info. Adapt for physical problems, suggest dosing syringes, ask for large print labels.
Practical solutions.
And tragically, you also have to be aware of the possibility of abuse. Caregiver abuse, financial or physical, can sometimes manifest as the patient not getting their meds. You need to look for those signs too. Unexplained bruises, dehydration. It's a tough reality, but crucial to consider.
Heartbreaking, but essential. Okay, let's shift gears now to the core pharmacology. The fundamental ways the body itself changes with age, impacting drugs.
Right. This is where we see the biology really shift. If you look at population data, the functional capacity of most major organs, kidneys, lungs, heart, shows this pretty steady decline. And it often starts earlier than people think, like in young adulthood.
Not just when you hit 65 or 70.
No, the decline is often gradual, starting much earlier. Think of graphs showing things like glomerular filtration rate, kidney function, maximum breathing capacity, cardiac output. They tend to slope downwards from maybe age 45 onwards.
No long middle-age plateau.
That's eye-opening, but you said population data.
Yeah.
It's not everyone, right?
Exactly. That's the critical caveat. These are averages. Individual variability is huge. About a third of healthy 75-year-olds show basically no drop in kidney function compared to younger adults.
So you can't assume.
Never assume. But the overall trend leads to altered pharmacokinetics, how the body handles drugs. And the single most important change, clinically speaking, is usually that decreased kidney function. Other changes in diseases also affect pharmacodynamics, how the drug affects the body.
Okay, let's break down pharmacokinetics ADME. Absorption, distribution, metabolism, elimination. Starting with A, absorption. Does the gut just get less efficient at absorbing drugs as we age?
Surprisingly, not really. Age itself doesn't seem to cause major changes in drug absorption efficiency. The gut holds up pretty well.
Oh, but the conditions associated with aging can change the rate of absorption. Things like different eating habits, taking more over-the-counter stuff like antacids or laxatives, those can interfere. And slower stomach emptying, especially common in older diabetics, can affect how quickly a drug gets into the system.
So indirect effects, mostly. What about D-distribution? How drugs spread through the body. Our body composition changes so much with age.
Ah, yes. This is where we see really big direct changes. Compared to younger adults, older people have significantly less lean body mass, muscle mass drops,
Okay.
less total body water, but crucially, a much higher percentage of body fat, dramatically higher, especially in women, but significantly in men too.
More fat, less water, less muscle. How does that change drug distribution?
It changes the compartments the drugs go into. Water-soluble drugs have a smaller space to dissolve in, so their concentration might be higher. Fat-soluble drugs have more fat tissue to spread into, potentially leading to a larger volume of distribution and accumulation.
Makes sense. What about proteins in the blood that bind to drugs?
Also changes. Serum albumin, a major protein that binds many acidic drugs, tends to decrease. On the other hand, another protein, alpha-1 acid glycoprotein, which binds basic drugs, might actually increase.
So the amount of free active drug versus bound inactive drug can shift significantly.
Precisely. Which really matters for the initial dose, the loading dose. If less albumin is available to bind a drug, you might need a smaller loading dose to avoid too much free drug hitting the system at once. Digoxin is a classic example. The loading dose is often reduced in the elderly.
But for long-term maintenance doses?
For the steady-state effective maintenance doses, these distribution changes alone usually aren't the main driver for adjustment. It's more about clearance, which we'll get to. But reduced clearance definitely requires adjusting maintenance doses.
Got it. Okay, let's move to M, metabolism, mostly the liver's job. Does liver function just decline across the board with age?
For some drugs, yes, definitely. The liver's ability to metabolize them slows down. But, and this is key, it's not universal for all drugs. Things like alprazolam, diazepam, propranolol, they're clearly metabolized more slowly.
Which metabolic pathways are most affected?
The biggest changes seem to be in phase I reactions, the ones involving the P450 enzyme system. Phase II reactions, the conjugation steps, seem much less affected by age itself.
Okay. Does blood flow to the liver matter?
Hugely important. Liver blood flow decreases quite a bit with age, maybe down by 40–45%. For drugs that are heavily extracted by the liver on the first pass, less blood flow means less drug gets metabolized initially.
And the liver's ability to bounce back from injury?
That also seems to decline. So after something like hepatitis or alcohol damage, even if the person seems recovered, their liver's metabolic reserve might be lower. You need extra caution with liver-cleared drugs.
And other health problems can impact liver metabolism too, right?
Absolutely. Malnutrition is more common, affecting enzyme production. Heart failure is more common, and that reduces blood flow to the liver. It's often a combination of factors.
So can you give a couple more examples of drugs whose liver clearance does decrease with age, and maybe some that don't change much, just to highlight the variability?
Sure. Decreased clearance is seen with drugs like imipramine, theophylline, nortriptyline.
Yeah.
But then you have others like warfarin, lorazepam, oxapam, ethanol, where hepatic clearance doesn't seem to change much with age alone. It really underscores that you have to know the specific drug.
Very drug specific. Okay, finally, E, elimination. Mostly the kidneys. This seems to be the really big one you flagged earlier.
It really is often the most clinically significant factor. The kidneys are workhorses for drug clearance. And in about 2/3 of people, kidney function, measured by creatinine clearance, or eGFR, declines progressively with age. The kidneys physically get smaller too.
Okay, less efficient filtering. But here's that tricky part you mentioned. Why doesn't the standard serum creatinine blood test always show this decline?
Right, this is the clinical pearl, the potential pitfall. Serum creatinine doesn't reliably rise in proportion to the decline in kidney function. Why? Because creatinine comes from muscle breakdown, and older adults typically have less muscle mass.
Ah, so they're producing less creatinine in the first place.
Exactly. Less production, less filtration. The level in the blood can look deceptively normal, even when kidney function is significantly impaired, like our 77-year-old case study. His creatinine might look okay on paper, but his actual clearance could be much lower.
That is such a crucial point for anyone prescribing or monitoring meds, so the direct consequence of this often hidden decline.
The drug's half-life gets longer, it hangs around in the body longer, risk of accumulation, risk of toxicity if you don't reduce the dose or dosing frequency.
How do doctors estimate the right dose then, if serum creatinine alone isn't reliable?
Many dosing guidelines now build in adjustments for age, and we use formulas to estimate kidney function, like the Cockcroft-Gault formula. It uses age, weight, and serum creatinine to give a better guess of the actual clearance.
Can you quickly run through that formula?
Sure. It's roughly 140 minus age times weight in kilograms, all divided by 72 times serum creatinine in mgdl. And then you multiply the result by 0.85 for women because of that generally lower muscle mass.
Useful tool. But it's still an estimate, right? Not perfect for everyone.
Absolutely. Crucial point. It's a population estimate. Remember that 1/3 of elderly might have perfectly normal kidney function for them. This formula might lead to underdosing.
So caution is key. Better to start low.
When in doubt, always start low and go slow in the elderly. There are also newer formulas, like MDRD, often used in online calculators.
And if you need a really accurate measure,
the gold standard is still a formal 24-hour urine collection to measure creatinine clearance directly. And remember, things like severe dehydration can temporarily worsen kidney function even further, but that's often reversible with fluids.
Good point. Okay, we've covered kidney elimination thoroughly. What about other routes, like the lungs? You mentioned that briefly.
Yeah, the lungs are important for volatile anesthetic gases. But because older adults often have reduced lung capacity and more lung disease, inhalation anesthesia is just used less often. They usually prefer intravenous agents where elimination isn't so dependent on lung function.
Right, makes sense. So we've tackled pharmacokinetics, how the body handles the drug. Now, pharmacodynamics, how the drug affects the body. There used to be this idea that older adults were just universally more sensitive to everything. Is that accurate?
That was the old thinking, yeah. That older people were just inherently more sensitive at the receptor level. But we now understand that a lot of that apparent sensitivity is actually due to the pharmacokinetic changes we just discussed, higher drug levels, basically.
Or the body just not coping as well.
Exactly. Or diminished homeostatic responses. The body's ability to compensate or adapt is weaker. Now, that's not to say there's no change in sensitivity. Clinical evidence definitely shows the elderly are more sensitive to some specific drug classes, like sedative hypnotics and opioid analgesics. And animal studies do suggest some real changes in certain receptors, like reduced responsiveness to beta blocker type drugs. But it's not a universal, more sensitive rule. It's more complex.
Okay, let's unpack those homeostatic control mechanisms. What are they, and how does aging blunt them?
Homeostasis is basically the body's ability to keep things stable: blood pressure, temperature, blood sugar, etc. These finely tuned feedback loops are crucial for how we respond to drugs safely. As we age, these systems often become less responsive, less robust.
Which makes the body more vulnerable to drug effects.
Precisely. The safety margin narrows. Take the cardiovascular system. An older heart can still increase output for moderate exercise, but it does it by pumping harder, stroke volume, not faster, heart rate, like a younger heart. It's a less flexible response.
And blood pressure control. You mentioned orthostatic hypotension earlier.
A huge one. While average blood pressure often rises with age, the body's ability to quickly adjust blood pressure when standing up often weakens. That leads to orthostatic hypotension, that dizzy spell or fainting feeling when you stand up.
Which is incredibly dangerous for fall.
Extremely dangerous.
Right.
Risk of falls, fractures, even reduced blood flow to the brain. Checking for that BP drop on standing more than 20 points systolic should be routine at every visit for older patients. It's a critical safety check.
Absolutely. Any other key homeostatic changes?
Yeah, glucose control gets a bit sloppier. Average blood sugar after meals tends to creep up with age. And temperature regulation often becomes impaired. Older adults don't handle cold or heat as well, making them more prone to hypothermia or heat stroke.
So it's a whole system becoming less resilient, less able to compensate, which ties into the broader life changes too, doesn't it? The behavioral and lifestyle shifts.
Absolutely. It all interacts. Cognitive changes, like we saw in our case study, directly impact medication adherence. Forgetting pills, getting confused about doses, often linked to underlying brain changes.
And the sensory issues, vision and hearing.
Massive practical impact. Poor hearing means misunderstanding instructions. Poor vision means inability to read labels or measure doses. These aren't small things. They directly affect whether medication is taken safely and effectively.
And then the psychosocial factors. Losing a spouse, financial stress.
Huge life changes. Loss, isolation, reduced income coinciding with increased health costs. It all creates a more challenging environment for managing health and complex medication regimens. It's a very different picture than for younger adults.
Okay, let's dive into specific drug groups now because how they interact with these changes is critical. Starting with CNS drugs, sedative hypnotics like benzodiazepines, Valium, Xanax types, and barbiturates.
Right, these need extreme caution. Their half-lives can increase dramatically 50 to 150% longer between ages 30 and 70. They just stick around much, much longer.
And some have active metabolites, you mentioned, making it even longer.
Exactly. The parent drug is active, and its breakdown products are also active. Combine that with reduced kidney and sometimes liver clearance and maybe changes in distribution. The effect is significantly prolonged. Though some, like lorazepam and oxazepam, might be a bit less affected, potentially safer choices.
And is there increased sensitivity too, beyond just the drug hanging around longer?
Generally, yes. It's thought elderly patients vary more in their sensitivity, and they're definitely more prone to the toxic effects like ataxia, poor coordination, instability.
Leading to falls.
Directly leading to increased falls and fractures, a major, major risk with these drugs.
Okay. What about analgesics, painkillers, especially opioids?
Opioids are tricky. Pharmacokinetics vary. But the big concern is increased sensitivity to respiratory depression, slowing down breathing. Age-related lung changes make this risk higher.
So extreme caution needed.
Absolutely. Start low, go slow, titrate very carefully to find the dose that gives pain relief without dangerous sedation or breathing problems.
Are they equally good for all pain types in the elderly?
Generally less effective for chronic pain compared to acute pain, like from a fracture. And there's this paradox. They're often underused for severe chronic pain, like cancer pain, where they could really help quality of life. But they've also been massively overprescribed for less clear indications, contributing to the addiction crisis. It's a tough balance, but good pain management is possible and crucial.
Moving to antipsychotics and antidepressants, also heavily used.
Yes. Traditional antipsychotics, phenothiazines, haloperidol, used a lot, sometimes misused, for various psychiatric issues, agitation, dementia behaviors. They could be useful for some things like late-life schizophrenia or acute delirium symptoms.
But not a magic bullet.
Definitely not. And you can't just keep increasing the dose hoping for full control. Importantly, there's no evidence they help the core cognitive symptoms of Alzheimer's. In fact, their side effects, especially the anticholinergic ones, might make memory worse.
So any benefit for agitation might just be sedation?
Often, yes. If sedation is the goal, maybe a sedative one, like thiordazine. If not, haloperidol or an atypical. But haloperidol has those extrapyramidal risks, Parkinson-like symptoms, especially bad if they already have issues.
And the orthostatic hypotension risk again?
Big risk with phenothiazines especially, that alpha blockade effect. You have to start with tiny doses, like a fraction of the usual adult dose. The newer atypical antipsychotics might have fewer of those autonomic side effects, but aren't necessarily much better overall for efficacy in this group. Olanzapine maybe has slightly stronger evidence.
What about lithium for mania? Kidney clearance is the issue there.
Exactly. Lithium is all kidney clearance. Dosage must be adjusted for renal function and blood levels monitored religiously. And watch out for thiazide diuretics. They reduce lithium clearance, requiring even lower doses and more frequent checks.
And antidepressants. Often underused, you said.
Tragically, yes. Major depression is thought to be missed a lot in older adults. Symptoms like apathy, withdrawal get mistaken for dementia. But they do respond to treatment, just like younger people, though they're more prone to side effects.
Which ones are preferred?
SSRIs are often the first choice because they have fewer of those bothersome anticholinergic side effects, dry mouth, constipation, compared to the older TCAs. If you do use a TCA, pick one like nortriptyline or disipramine, which are generally better tolerated in that regard.
Briefly, tremor. Essential tremor is common, right?
Very common. That shaking, both at rest and when trying to do something, can be really disabling for daily activities. Beta blockers like propranolol or sometimes benzodiazepines like alprazolam can help manage the symptoms.
Now the big one, Alzheimer's disease. Our case study showed clear signs. It's such a devastating condition.
Truly devastating. Progressive memory loss, dementia, cognitive failure, leading eventually to total dependence and early death. and incredibly prevalent, maybe 20% of over 85s. The cost, personal and societal, is just enormous.
What's the latest on causes and pathology? Genetics play a role.
Yes, there are rare early-onset genetic forms linked to specific genes like presenilin-1 or related to Down syndrome. For the more common late-onset form, the ApoE gene is important. Specifically, the A4 variant increases risk and correlates with amyloid buildup. Lots of research now is trying to find early biomarkers, like measuring amyloid beta, 8-OFA in the blood, or identifying protective gene variants.
And it seems like the brain's immune system, the microglia, are key players.
Increasingly, yes. A lot of the genetic risk factors seem to converge on how microglia function and respond to the amyloid plaques. There's a complex interplay between genetics, inflammation, and the disease process.
And the physical hallmarks in the brain are those amyloid plaques and tau tangles.
Those are the two main ones. Extracellular plaques made of apeptide and intracellular tangles made of abnormal tau protein. This leads to widespread loss of neurons, especially the cholinergic ones, these acetylcholine producers, and thinning of the cortex.
Inflammation is involved too.
Yes, definitely. There's evidence of neuroinflammation involving things like the NLRP3 inflammasome. Some animal studies even showed certain NSAIDs could reverse inflammatory markers, suggesting it's a targetable aspect.
And the loss of those cholinergic neurons is why anti-cholinergic drugs are so bad for AD patients.
Exactly. They're already low on acetylcholine, so blocking its action further really worsens cognition.
Yeah.
There's also evidence implicating excess glutamate activity, another neurotransmitter, in neuronal damage.
Any other newer pathways being looked at? Fin protein, mitochondria, viruses?
Yeah, lots of angles. Fin kinase activation by ID seems to mess up synapses.
Yeah.
Inhibitors are being tested. Mitochondrial dysfunction problems with the cell's energy factories is implicated. And there's that really provocative recent idea linking herpes viruses to triggering AD and tau problems, raising the possibility of prevention through vaccination someday.
Wow. Okay, treatment strategies. What's actually available and how well does it work?
Well, many things have been tried. Most offer only modest, temporary symptom improvement. They don't stop the underlying progression.
The mainstays have been the cholinesterase inhibitors, right, to boost acetylcholine.
Yes. Drugs like donepezil, rivastigmine, galantamine replace the older, more toxic tacrine. They provide a statistically significant benefit, but clinically it's often modest and varies a lot between people, and they have side effects, nausea, diarrhea. They don't halt the disease.
What about targeting glutamate with memantine?
Memantine works differently, blocking NMDA glutamate receptors. Its efficacy is often similar to, or maybe even less than, the cholinesterase inhibitors, but it's generally better tolerated. Combining them doesn't seem to add much extra benefit based on current studies.
Okay, the most direct approach seems like targeting the amyloid plaques themselves. How's that going, especially with those antibody drugs?
That's been a real roller coaster. Early antibodies like solanezumab failed. Then aducanumab got controversial FDA approval. It clearly reduced amyloid plaques, but the clinical benefit on cognition was modest, debatable, and only seen at the highest dose in some patients. Newer ones like donanemab seem more promising, but it's still complex.
So removing plaques isn't necessarily the cure-all. What about preventing A production?
Tried that too, with BACE1 inhibitors like verubecestat. It reduced A production, but didn't translate into clinical benefit in phase 3 trials. Again, maybe too late in the disease process.
And targeting the tau tangles.
Also a major focus. Trying to stabilize microtubules with drugs like epoethylenine D. Still very much in development.
Why have so many trials failed? Is it because they start too late?
That's a leading theory. By the time someone has clear symptoms, the brain damage might be too extensive, too irreversible. The hope is for better, earlier detection methods so we can intervene when there's still a chance to make a real difference.
Are there any non-drug approaches showing promise? Lifestyle stuff.
Yes. That Finnish finger study was really encouraging. It showed that a combination healthy diet, exercise, cognitive training, social activity, managing vascular risks could actually reduce cognitive decline risk, even in people with genetic susceptibility. A holistic approach matters.
That's huge. Any other emerging drug ideas? Sildenafil? Statins?
Lots of things are being explored. PDA5 inhibitors, like sildenafil, showed promise in mice, and there was that retrospective survey suggesting lower AD risk in users, but that needs proper trials. Statins, PPAR gamma agonists, vaccines, anti-inflammatories, anti-FYN drugs. The list is long. Research is very active.
Okay, let's switch to cardiovascular drugs. Hypertension, high blood pressure, super common. Does it just keep going up with age?
Generally, yes, systolic pressure tends to rise, especially in Western cultures with high salt intake. And it's now clear, hypertension in the elderly must be treated. There's even evidence suggesting good BP control might help reduce dementia risk.
Wow, another potential link. Treatment principles same as for younger folks.
Mostly, yes. But all those cautions about pharmacokinetics and blunted homeostatic responses apply heavily here.
Yeah.
Always start with lifestyle changes, weight loss, salt restriction, because they're safe and can be effective.
And for meds, what's preferred?
Thiazide diuretics are often a reasonable start, but you have to watch electrolytes, blood sugar, uric acid, as older adults are more prone to issues like arrhythmias, diabetes, gout. Low doses are key. Calcium channel blockers are often effective and safe if titrated carefully, good if they also have angina.
Beta blockers, ACE inhibitors.
Beta blockers can be risky with lung disease, less useful than CCBs unless there's heart failure too. ACE inhibitors are less useful for uncomplicated hypertension unless there's also heart failure or diabetes. Really strong drugs are rarely needed.
And constantly checking for that orthostatic hypotension.
Absolutely critical. Risk of falls, fainting, must check BP standing versus sitting at every visit.
Okay. Digoxin for heart failure. You said it's often overused.
Yes, because heart failure is so common and serious. Yeah. But digoxin toxicity, especially arrhythmias, is really dangerous in the elderly. They're more susceptible.
How do its pharmacokinetics change?
Clearance is usually down, volume of distribution might be down, half-life is often way up, maybe 50% longer or more. It's mostly kidney cleared, so renal function is paramount for dosing.
Are they more sensitive to the good effects?
No evidence of that. Maybe even less sensitive therapeutically. But they're definitely more sensitive to the toxic effects, especially arrhythmias.
What makes them more prone to toxicity?
Things like low potassium, low magnesium, low oxygen levels from lung disease, underlying coronary disease, they all increase the risk of digoxin-induced arrhythmias. And other side effects like delirium or visual changes are also more common.
What about antiarrhythmic drugs in general? Sounds risky.
Very challenging. Less heart reserve, more electrolyte problems, more underlying heart disease. Drugs like quinidine, procainamide have reduced clearance, longer half-lives. Disopyramide is probably best avoided due to its side effects, urinary retention, worsening heart failure. Lidocaine needs dose reduction due to CNS toxicity sensitivity.
And for atrial fibrillation, which is so common.
Often just controlling the heart rate is as good as trying to force it back into normal rhythm. But anticoagulation blood thinners is absolutely essential in chronic AFib to prevent stroke, regardless of the RADA rhythm strategy.
Moving to antimicrobial therapy, infections are a huge threat.
Absolutely. Age-related decline in immune function, like T-cell changes, reduced clearance in the lungs, urinary issues like retention or catheters, all increase infection risk dramatically.
Antibiotics must have been revolutionary for longevity then.
Hugely impactful since the 1940s. Helping compensate for those declining defenses. The principles of use are the same, but again, pharmacokinetics, especially kidney function, are critical.
Because so many antibiotics are cleared by the kidneys.
Exactly. Most penicillins, cephalosporins, aminoglycosides, fluoroquinolones, their half-lives can lengthen dangerously if doses aren't adjusted for reduced renal function. Aminoglycosides are especially tricky because their toxicity is concentration and time dependent. Their half-lives can easily double or more in the elderly.
A clear danger zone. Okay. Anti-inflammatory drugs. Arthritis is almost universal.
Osteoarthritis is extremely common. Rheumatoid arthritis too, though less exclusively geriatric. NSAIDs are the mainstay but need extreme caution.
What are the main risks with NSAIDs in older adults?
With aspirin, it's GI irritation and bleeding. With the newer NSAIDs, it's kidney damage, which can be irreversible. Because they're kidney cleared, they accumulate faster, especially if renal function is already poor.
Creating a vicious cycle.
Precisely. Drug builds up, it damages kidneys more, drug builds up even more. And the complex too, selective ones. No proven safer for the kidneys. So anyone on high-dose NSAIDs needs regular kidney function monitoring.
What about corticosteroids? Powerful, but risky.
Very useful when NSAIDs aren't tolerated, but the big hazard is osteoporosis. They accelerate bone loss, which is already a huge problem, increasing fracture risk. Mitigating that with calcium, vitamin D, maybe bisphosphonates, and encouraging exercise is crucial.
Ophthalmic drugs for the eyes, glaucoma and macular degeneration.
Glaucoma treatment is similar across ages, but age-related macular degeneration, AMD, is the leading cause of blindness in the elderly in developed countries. Huge impact.
Are wet and dry forms, right?
Yes. Wet AMD involves leaky new blood vessels under the retina. Dry AMD is a slower breakdown of retinal cells, more common. Smoking is a big risk factor. Oxidative stress seems involved.
Treatment antioxidants help.
Antioxidant supplements, vitamin C, E, zinc, etc. are widely used, maybe offer modest benefit in slowing progression, but aren't a cure. For wet AMD, the big advance is anti-VEGF drugs.
The injections into the eye?
Yes. Drugs like bevacizumab, off-label, ranibizumab, aflibercept, pegaptinib, they target the vascular endothelial growth factor that drives new blood vessel growth. They can preserve, sometimes even improve, vision in wet AMD. Moderately successful.
Okay, we've covered a ton of ground. Let's talk adverse drug reactions, ADRs, a massive problem in this population.
Enormous. The overall rate is at least double that of younger people.
Yep.
And there's that direct, strong link to polypharmacy. The more drugs, the higher the risk.
What do the numbers look like?
In nursing homes, where patients are often on 6-8 meds, the ADR rate jumps from maybe 10% with one drug to nearly 100% with 10 or more. It suggests maybe half of long-term care residents experience an ADR, recognized or not.
Staggering. And it happens at home, too.
Oh, yeah. People see multiple doctors get overlapping prescriptions. That's why the brown bag review is so vital.
Bringing all their meds in?
Everything. Prescriptions, OTC, supplements, herbals. You ask them to dump it all on the table. You can often cut the number of meds by 30–50% just by spotting duplicates or unnecessary drugs. It's incredibly effective.
What causes these ADRs? Is it the doctor's fault? The patients?
It's usually a mix.
Yep.
Sometimes practitioners don't fully factor in the age-related changes or potential interactions, or they aren't aware of what other doctors prescribed.
Can you give an example?
Cimetidine, that common heartburn drug. Older people are more prone to its CNS side effects like confusion, but it also inhibits liver enzymes, blocking the metabolism of drugs like warfarin, phenytoin, beta blockers. Add cimetidine without adjusting the other drug, boom, toxicity risk skyrockets.
A classic interaction. What about patient errors? Beyond just forgetting.
Often involves OTCs or herbals taken without telling the doctor. They can have potent hidden ingredients. Antihistamines cause sedation, dangerous with cognitive issues, and anticholinergic effects can cause urinary retention or glaucoma. Ginkgo plus aspirin increases bleeding risk. Patients often just don't realize these interactions.
It feels like a minefield. So what are the practical takeaways, the guiding principles for actually doing geriatric pharmacology well?
Despite the complexity, the goal is achievable. Intelligent drug use can massively improve quality of life. But you have to address the practical hurdles.
Like cost.
Absolutely. Cost is a huge barrier for people on fixed incomes. Prescribers must be aware of cost, no cheaper alternatives. Generic ibuprofen versus a pricey new NSAI can make the difference between adherence and non-adherence.
And tackling forgetfulness and confusion.
Keep regimens simple. Multiple drugs, different schedules, different doctors. It's a recipe for error. Patients often stop antibiotics early when symptoms improve, especially if they were expensive. You need clear communication, maybe pill organizers.
And that intelligent non-compliance.
Talk about it. Find out why they don't want to take it. Maybe they had a bad experience. Listen, understand their perspective. Make them a partner in the decision-making. That boosts motivation and adherence way more than just telling them what to do.
And the physical barriers, vision, hearing, dexterity.
Practical solutions are key. Confirm hearing by having them repeat instructions. Use written instructions. Dosing syringes for liquids, not spoons. Request easy open caps if arthritis is an issue. Demand large print or color-coded labels for poor vision. Simple things make a huge difference.
It really comes down to thoughtful, individualized care. So can you summarize the key principles for prescribers, the how-to for better outcomes?
Okay, 5 core principles. 1, take a careful drug history every time. Include everything OTCs, herbals, use that brown bag method. Is the current problem drug-induced? Are there potential interactions?
Got it. Number 2.
2, prescribe only for a specific rational indication. No vague prescriptions. Use evidence-based guidelines. Know why you're giving each drug. 3, define the goal. Start low, go slow. Titrate carefully. Wait at least 3 half-lives adjusted for age before increasing the dose. If no response at a normal dose, check blood levels if possible. If still no response at adequate levels, rethink the diagnosis or switch drugs.
Systematic. Number 4.
4, maintain a high index of suspicion for ADRs and interactions.
Yeah.
Assume they can happen. Know all the substances the patient is taking. Be vigilant.
And the 5th principle?
5, simplify the regimen. Use drugs with similar dosing schedules. Consolidate where possible. Actively try to reduce the total number of drugs. In geriatrics, less is very, very often more. Better adherence, fewer side effects.
Wow, that's a powerful summary. We've really journeyed through the whole complex world, defining elderly, the deep dives into pharmacokinetics and pharmacodynamics, specific drug classes, the pitfalls of ADRs, and finally, these crucial practical principles.
And grasping all that interplay of biology, pharmacology, and individual patient factors,
Yeah.
that's what enables truly effective, safe drug therapy for older adults. It's what allows elite professionals to genuinely improve both quality and length of life.
It's knowledge that's only going to become more critical as our population ages. So maybe a final thought for you, our listener, to take away. Thinking about all these complexities, the impact of aging, the challenge of polypharmacy, what steps can you take or advise others to take to make sure medications remain tools for health, not sources of harm as we get older? And looking ahead, how do we ensure our health span keeps up with our lifespan? And what role will this kind of intelligent, patient-focused pharmacology play in shaping that future?